am.
Okay.
So our next presenter is going to be Teddy Wu and Christy Ankrom. They're going to be both talking about setting up telehealth in the COVID-19 era. It'll be a 45-minute presentation followed by a 50-minute question and answer.
Okay, so I think I guess we'll start right on time. Hi, I'm Teddy Wu here at UT Health in Houston, Texas. Christy and I will be discussing setting up a telehealth practice. I'm going to be more tackling the inpatient aspect of things, and Christy will be talking more regarding the outpatient changes that we've made during this crisis. So let me control the slides here. Where we both have no financial disclosures. So the objectives of our quick talk is to talk about the state of teleneurology pre-COVID-19 from the inpatient and outpatient aspect, review the methods of how we implement the teleneurology services on both sides, and talk about how we think teleneurology may operate beyond COVID-19. So I'm going to be talking about telestroke and how we've approached that even before. I'm sure a lot of people on the talk have been exposed to telestroke and are probably actively doing it now. I'll talk about how we've transitioned from acute telestroke practice to now inpatient teleneurology and how that's changed during the crisis, and how we've implemented virtual teaching rounds at our local comprehensive stroke center with our residents and fellows. So why do we need teleneurology, telestroke? I'm sure everybody knows, and I don't have to kind of regurgitate a lot of this information, but now we have a disease that is still the leading cause of long-term disability in the United States, and very good therapies for it, specifically IVTPA. It's a very, very powerful medicine for patients that do not have large vessel occlusions. It's still a very useful treatment. We know that intra-arterial thrombectomy, very powerful treatment for our patients with large vessel occlusions. Again, very low number needed to treat. But we do know that both treatments need to be delivered fast in order to be effective, and that despite all the progress that we've made, TPA is still underutilized at many centers and many hospitals throughout the nation, and that we need to improve access to intra-arterial thrombectomy. And telestroke and teleneurology definitely can help with that. We know that there are about 800,000 stroke cases a year. You know that as our population continues to age, that's likely to be doubled in 2050. And there continues to be a shortage of neurologists throughout the United States. When I'm just talking about general neurology, but for vascular neurologists, we know that there's definitely a shortage of those as well. We've definitely witnessed a significant decline in the number of neurologists taking hospital call and even inpatient consultations, and we'll talk about how that led us to do teleneurology from an inpatient aspect. And that all can lead to a lack of access of acute stroke expertise. Now, for those that have practiced in large centers with really great emergency room physicians, I think that's a wonderful situation to be in, but it's not always the case. The ER physicians that have not had a lot of experience or not dealing with a lot of stroke patients, a lot of them are uncertain about administering IVTPA without the guidance from a neurologist. And they may have not even potentially kept up with all the rapid treatments that are available with intra-arterial thrombectomy, all the different time windows that we have, and all the necessary testing that goes along with that. So again, telestroke can definitely lend a hand into those aspects of things. And one of the biggest things that we try to tackle through telestroke is to hopefully even out the disparities in acute stroke care throughout the rural population. Data definitely shows that if you are in a rural hospital compared to urban hospitals, you're 10 times less likely to receive IV lytics. And as we all know, then your access to other therapies such as thrombectomy are also going to be a little bit lower. And for us in Texas, and it's very, very important because we do have one of the largest rural populations as far as the states are concerned. So the different coverage models, and I think one thing we'd really want to be able to at least share in our experience in our network is we're very, very flexible. It is not a very rigid model that we have, but every hospital that is either providing the service or a group of physicians that are providing the service, and vice versa. They all are going to want different services or provide different services, but this is just kind of what we do. Our acute telestroke coverage model, in a sense, we're providing acute stroke care in remote hospitals that lack neurological presence, and that could be lacking completely, no neurologist at all, or they have sporadic neurological presence, either in-house, providing inpatient care, or just purely outpatient care. We know that for smaller markets, smaller community hospitals, it is very, very difficult to attract neurologists to their communities. People tend to like to live in bigger cities with, bigger hospitals, more patients, and for them to be going to a smaller hospital, it's very, very difficult to attract neurologists to stay there for the long term. And it's even more difficult to attract and recruit vascular trained neurologists. So when you already have difficulty recruiting into those markets, it makes it very difficult to also maintain a call schedule if you only have a few neurologists to kind of go around. For even hospitals that have neurology practices and local neurohospitalists, our telestroke coverage can help to enhance call schedules. So if you have 3 neurologists that cover 1 week a month, we can help cover that 1 week that's uncovered in that month, and that offers them a lot of flexibility. And what we do is, if we do all the acute teleneurology aspect of the care in the ER or on the floors, our local neurology partners can maintain an outpatient practice and don't have to run back and forth from their clinics to the hospital. So that makes it very, very attractive for them to continue to provide that coverage in the hospital without having to sacrifice that aspect of their outpatient practice. So why do we need routine teleneurology? And there's, again, a few reasons behind that. So when I talk about routine teleneurology, we're talking about coverage of routine or non-urgent teleneurology consultations on the floor. And a lot of that has to do with the lack of neurology coverage. It's very difficult for them to recruit. It becomes financial burdensome for local neurologists. And we've noticed in a lot of our community hospitals that the local neurologists are now refusing to go in to provide consultations in the hospital. It makes it very difficult for them to do that. Financially, they're disincentivized to do so, and they don't even go into the hospital to see their own patients. In addition, for hospitals that we are providing coverage with for telestroke, what they've noticed is that they have no neurology at all in their community. They were transferring all of their TPAs or all of their patients because their hospitalists that are medicine trained were uncomfortable in taking care of the patients if they got admitted. They noticed that the family of those patients didn't want to travel, or the patients didn't want to travel, and they really wanted to be able to keep more patients locally and have that neurological backup that they weren't able to have. And obviously, from a financial standpoint, our spoke hospitals with more patients they're able to keep, and they're able to keep locally, they're able to capture that downstream revenue with more outpatient imaging, physical therapy, rehab, et cetera. So it becomes very, very important. So that's why we've noticed that a lot of our hospitals that started with us as a spoke hospital for telestroke specifically are coming back to ask us to cover them in the hospital for the teleneurology aspect of things. So the role of teleneurology, and when I say teleneurology on this slide, I'm talking about encompassing the entire range of what we do. We provide acute neurological consultative services, so not just telestroke, anything acutely neurologic 24/7 in the emergency room or in the hospital. And we supplement either the current neurological coverage or wear their entire service. We're very flexible. Example of patients that we take care of, obviously, up-intentional acute stroke patients, patients with hemorrhages, status epilepticus, a lot of headaches for the teleneurology aspect of things. For patients that we've identified in the emergency room or in the hospital, less so, but or in the emergency room that need to be transferred to our comprehensive hubs, we definitely help expedite that process. And we are allowed to then pre-accept them to our local hospital, in which we have privileges to. And again, we talked about providing non-urgent consults as well and follow-ups. Current staffing, this is again our program, our structure. We're a very, very small network in a sense of our staff, but for the 24/7 365 acute neurological coverage, we have 16 spoke hospital and 7 freestanding ERs. During the day, Monday through Friday, that's 8 to 5. We have one telemedicine faculty member that covers that. On the weekends, we have an on-call person, and after hours, we have one on-call person. We're lucky enough to have four full-time telemedicine faculty in our institution. One is doing the acutes, 2 would be providing the routine neurological consultations or that teleneurology, teleneuro hospitalist service at 5 spoke hospitals throughout the week, and a more skeleton crew on the weekends. I think this is, I tend not to focus a lot on what specific telemedicine technology we use, but we do use InTouch, but I think you can use any technology that you want to provide that inpatient services through teleneurology. But we do feel that it is important to have technology that is easy to use, that is very, very mobile. And continuous monitoring of connectivity is key. Having reliable equipment that the nurses or the ER staff don't have to fiddle with too much is very, very important. And having an excellent service team to quickly troubleshoot problems is very, very important. We've definitely noticed that during the crisis as we've had some issues with networking, and being able to fix those problems is very important. So what have we learned, and how have we changed our teleneurology service and telestroke service during COVID-19? To be honest with you, I think our workflow changes are very minimal, and kind of briefly go over some of those things. But as our previous speaker had mentioned before, we definitely have seen a decreased number in our overall acute and routine teleneurology consult volume. However, I do feel that, again, anecdotally, I haven't had a chance to run all that data. The patients that we're seeing with the large vessel occlusions has been relatively steady. So we're still identifying patients with large vessel occlusions and sending them to IA as needed, but we have revised some of our patient selection criteria, which I think some of the other speakers may kind of go into, and we have halted our clinical trials related to arterial thrombectomy. One change that we did make at some of our sites regarding telestroke deployment is that we had about 6 of spoke sites that had in-house coverage during the day. Because we want to lessen the exposure for the patients and the clinical staff and the even the ER staff as well to more physical contact, we transition those 6 sites into telestroke coverage even during the day, even if the neurologist was in-house. Some of them decided to do telestroke in the hospital themselves, and some transitioned to our network covering them during the day, and obviously the things at night would stay the same. Some of the changes that we had to our workflow, again, with some of the things that the previous speaker definitely talked about, is minimizing exposure, making sure that everybody has important PPE as needed, and also cleaning the devices as we move from room to room to ensure that we're not also spreading COVID as well. So kind of switch gears and talk about how do we use telemedicine in our big teaching hospital here at the TMC in Houston. When the crisis started, we quickly instituted virtual rounding using WebEx to encourage social distancing from our stroke team, which consists of an attending, a stroke fellow, and 3 to 4 neurology residents. We wanted to limit the unnecessary physical and neurological examinations. So in our neuro ICU, we only had our attending see the patients who were not having 3 or 4 people on the same team, seeing and then touching those patients that possibly could be spreading the virus. Only the attendings are seeing the COVID positive patients because we want to reduce exposure to the entire team, and we also want to conserve PPE. For our inpatient codes for COVID positive patients, One thing that we kind of jumped to, and I think the other speaker talked about that, is to obtain all the scans that are necessary up front so that we're not moving the patient back and forth, because that definitely could delay care as needed. And obviously, being very, very careful with PPE and using telemedicine for those things if possible. Here's an example of how we are using our virtual rounding. So on the left panel here, we have our stroke attending that is moving this iPad around, and we're having a WebEx virtual rounding session. We have our stroke fellow, Christy Chu. Our stroke attending is Alicia Zha on the top left corner, and then we have 3 neurology residents are going from room to room with the attending. She's the one that's taking the picture, and they're able to see all and examine the patients together and make plans as necessary. Again, all this is to increase social distancing and having not allowing the team to kind of aggregate together and being too close to each other. All of our neurology residents are sitting in a room 6 feet apart, so they're not also getting too close to each other as well. So some of the lessons learned, I think it's for us, even before that, we've had a very experienced and dedicated telemedicine team with physicians that have done telemedicine in the past and during fellowship, and a very experienced program manager. I think, even before or after, what we realized that the more simplified the procedures and the protocols are, the much more easy you're able to adapt and be nimble as things become more complex, as we've definitely learned with COVID-19. Technology, you want to minimize things so that people don't have to learn a new skill when things like this happen. And we want to minimize the workflow changes to the on-the-ground team to ensure that despite these crisis type of events, we're not teaching too much on the fly. Having clear communication channels of knowing who to reach quickly with information, with changes in phone numbers or changes in protocols and practices is key. So knowing all the stroke coordinators and who to contact at all the spoke sites, our ER our ER managers are very, very important, and remaining nimble for changes is very, very important. I think one thing that we are going to probably struggle with is, as more and more of other specialties are getting ramped up to using telehealth now during the crisis, they're probably going to want to do more after. So being able to then share equipment and being able to have simultaneous sessions, or potentially 2 services needing the same equipment at the same time, those are the things you're going to have to work out as well. So with that, I'm going to hand that off to Christy, which will talk more about the outpatient telemedicine aspect of things, and feel free to ask more questions. Thanks. So any screen, if you want to unmute Christy.
There we go. Hopefully you guys can hear me now. Again, Dr. Wu mentioned, I'm Christy Ankrom, and I am the program manager over our telemedicine side. I'm going to talk to you guys a little bit about sort of the massive changes that we made to be able to adopt outpatient telemedicine very quickly. And just to give you an idea of where we came from, as an industry, telemedicine in general, before COVID-19, adoption for outpatient was pretty low. There are some big exceptions to that. Some health systems that really got on board with telemedicine early and were giving that to their patients as a way to sort of increase quality and access to their physicians. And a lot of times they did it at their own expense because, of the regulations. But also commercial businesses, these big, large commercial telemedicine platforms that you see, like American Well, and you pay your cash and you see whatever doctor is on call. That was still pretty robust. And also health plans had really gotten on board with offering telemedicine to their plan subscribers. The regulations on telemedicine at the state and federal level were completely all over the map. Reimbursement was the biggest obstacle for a lot of people doing outpatient telemedicine. Getting access to patients by telemedicine at their home, by and large, wasn't allowed for most Medicaid patients and Medicare patients. And commercial plans were very hit or miss. Interstate licensure was a huge barrier. You couldn't cross state lines without either being in that federal compact situation or getting a license in the state where your patients were located. And also perception. The adoption perception was pretty low because they felt that telemedicine was an inferior delivery of care. And while we still don't have all the data on whether or not that's true, I think COVID-19 is really going to provide us an opportunity to address that specifically. So here at UT Health, we're in Houston. We're in the largest medical center in the United States. And you can imagine that telemedicine wasn't very prevalent. We have a real big saturation of providers. But UT Health specifically decided last year that this was a direction that our patients would want to be in. We have a lot of patients in the city, and getting into the Texas Medical Center is a huge, huge obstacle for a lot of people. So we were in the process of standing up a practice plan, wide outpatient telemedicine platform. So this platform was going to integrate with our business system so that we could schedule through our scheduling system, and we could bill patients or copay through that platform. But it didn't integrate with our EHR because we're transitioning next year to a new, large, very popular platform called Epic. So we chose to not build that initial integration with our current EHR. We were, as of the beginning of March, we were about 8 to 10 weeks away from going live with our integrated product. But then COVID happened. So, and that, up to that point, really only post-surgical practices, research projects, and grant-based care were our only big outpatient telemedicine reach points. So this platform was going to allow a lot more people to have a way to see patients by telemedicine, despite all of the other regulatory obstacles. This is telemedicine for COVID-19. It literally is the Wild West. You cannot pick a regulation that existed before COVID-19 and say it's in place now, because literally everything has been lifted. HIPAA restrictions, which was a big deal. FaceTime, Skype, Zoom, WebEx, whatever has a video and you can see your patient, except for like Facebook Live and TikTok. I think those are some things that they mentioned. It didn't matter. It didn't matter if your institution had a BAA with these places. It really just was all about giving access to things that were easy to use and immediate. Consent can be verbal now. Prior to COVID-19, consent had to be written and had to be on file. And we now can just consent the patient in the moment and document that in their note. Nearly every billing restriction has been lifted. Even phone consults are widely reimbursed. So those Medicare restrictions for seeing patients at home, all the Medicaid restrictions, there are just really every barrier possible has been removed. Licensure is still a problem. I know CMS says that the interstate thing is no longer a concern right now, but you still have to abide by whatever state medical board regulations for telemedicine there are. So if you are going to practice across state lines, you should double check with that state's medical board if you don't have a license, and make sure you're doing everything the way that they want you to. Of course, adoption has skyrocketed. I know the speaker that was just before us mentioned that, they are doing all kinds of outpatient care. And I can't even begin to tell you how widespread telemedicine adoption is now across the country. And that leads to patients being seen in unprecedented numbers. And I know just for us personally, it's been really a savior. So here at UT Health, in the midst of all this, we kind of took a little risk-averse approach to it. We are not so much the Wild West, but if you've ever been to Disney World at Christmas, it's like a controlled chaos. That's kind of where we are now. Our neurology department, we initiated virtual care within 24 hours. I was actually at Disney World at the beginning of March, and the day I got back from vacation, my chair's like, we need to start seeing patients tomorrow by telemedicine. And luckily we have a long-standing telemedicine program. I was already building a platform with the university, and I was ready to go. And like, look, right now, all we can do is use Zoom because we don't have to program it. It's fairly easy to use. So we rolled out with Zoom. And then immediately after, during that process, we were flipping the system that we had decided to start building last year. So we removed all of the features and just rolled out that core platform without any integration. And in 6 weeks, we brought up 135 clinics. But overall, visits across the practice plan are still below normal volume. There is a degree of people who are uncomfortable with telemedicine. Maybe they don't have a device at home that is capable of seeing someone by video. And then there are that small population of people that really just need to be seen in person. And then we're still in the midst of all this building that integrated platform in the background. So like I mentioned, a 24-hour turnaround on us using Zoom with no integration. If you aren't doing telemedicine yet for your patients, there is really no barrier for you to do that other than if you just don't have anyone behind you that wants to do it too. The first patients in our practice that were seen were neuromuscular patients and movement disorders patients. We had a couple of practitioners that were at risk that needed to be home immediately, and they were the first two to really take this and run with it. And they proved the utilization to the rest of the faculty, and I think it made everything easier to adopt. We were sending patients their links to their visit through the patient portal if they had access, or through a secure email process. But the workflow is clunky. Providers had to go into Zoom to schedule those individual visits. We wanted to make sure we had a clear one-to-one record with the Zoom visit and the patient's visit, should we ever have to go back and reconcile those things. We trained everybody intensely for a week. We separated provider and staff training. We recorded webinars so that people could come back and see them later for a refresher. But after that first patient was seen with Zoom, we were off and running. We actually already had a business associate agreement with Zoom. And we sort of took all the new changing reimbursement regulation, compiled it into a massive billing guide. I sent that out to everyone so that they could know what codes to use for what type of patient, to what RVUs were they going to get, how much was that going to get reimbursed, and it allowed them to make really informed decisions about all that. We were doing telephone visits in the middle of all of this as well, and we really just ran behind getting patients access to our providers. Our providers are actually asked to come into the clinic first to see their patients on the computer in the clinic. That was so I could be physically on hand and help walk through any troubleshooting, real-time issues with patients connecting. But for the most part, as long as your patients were sent a leak in advance, anywhere from 1 week to 24 hours, we had very little technical issues. Those issues arised when we would send same-day links to their appointments. We had a lot more technical problems when that happened. One thing we did decide to do was use Qualtrics to create our new patient forms. Because there is no integration with the Zoom platform, we built a form inside of Qualtrics to create this secure new patient survey so that we could expand our adoption to new patients. That new patient form can be sent back and forth through the patient portal, but we were finding most new patients didn't have access to the portal yet, so we had to come with a workaround for that. And initially, our patients were consented verbally. We have now uploaded the ability to put that consent in the portal, but by and large, most of our patients have not chosen to go with the patient portal. So then that was neurology, and in the middle of neurology doing this, the whole practice plan started working on that, the basic framework of the platform we were building. And that was TeleHealth, their solo platform. There again was no integration, just like Zoom. And but because of the work we had already been doing for that previous, 7 or 8 months, we had already had the single sign-on built in. So that made it easier for us to connect our users to the platform just by having them do their single sign-on for all of their university resources. Departments were enrolled in this platform on a first-come, first-served basis. So the more motivated the department was to offer this to their patients, typically the faster they got their information in. And we had to take that list of users that they had supplied for their waiting room, physically create it, and assign people. And in the middle of that, we were having trainings 3 to 4 times a week for 300 to 400 people at a time. And we would have staff trainings, we would have provider trainings. We recorded those webinars for reference. But what we were finding is that this whole process of getting a clinic off the ground took 5 business days each. Now, these timelines were all sort of concurrent at times, but it was taking a full calendar week to get everyone set up. And we were working 7 days a week for sure. We had daily team calls. The project team would get together, talk every day. We would discuss issues. We would discuss workflow problems, workflow changes. What documentation do we need? We spent an hour on the phone every single day. That is now down to 2 days a week. But in the beginning, those daily team calls were really, really helpful. We also had daily calls with the vendor. As we had this massive ramp up of use in this platform, we discovered weaknesses in the platform. You know, it's one of those things where in telemedicine, you have to actively use it and break it in order to know how it can work better. And we are still breaking this platform every day. And I think at the end of this, everyone's going to come out with a much better system and product. We were doing IT support at the department level. There was no call center where our patients could call in and get technical support, or where our providers could call in and get technical support. So we started tracking these IT issues on an interactive spreadsheet to check for common concerns and common issues, so that we could then take good information back to the vendor and say, we have identified this is a real problem and it's happening in these instances. And anytime you're doing something new, collecting as much detail about that problem that you can help, nothing but help you solve it further down the road. We built a telehealth toolkit, which I'll talk about briefly in a second, but we also developed these quick resources guides for patients, staff, and providers, so that they had a quick way of going, oh, how do I log in? Oh, what happens if my camera doesn't work? So we have these little quick one-page guides for everyone, so they don't have to look through the entire toolkit. But the toolkit is a tome of massive and important information. It is a comprehensive sort of guide for all the departments that are starting telemedicine, especially departments doing telemedicine for the first time. It helped define the visit types. It helped define documentation requirements. Our billing guide got incorporated in there for both phone and video encounters. We gave departments regulatory guidance. We're keeping up with all of the changes going on in both the regulatory and state level, or federal and state level. We took a peek at controlled substance prescribing. It gave people guidance on that because we were finding that that was a common question. We discussed ACGME concerns and medical board updates. We also included our best practices, and because Neurology had been doing this for a while, we had a lot of good information to provide as far as best practices go. But like anything, it's not a one-size-all, kind of solution. Every department had a little bit of tweak for that best practice, and it gave us a really good guide on every possible scenario. So for Neurology, for COVID-19, I am really proud of the way that our department responded to this crisis in many ways. Our chair held a conference call 3 times a week, Monday, Wednesday, Friday. They provided everyone with a venue to talk about what's changing, to talk about telemedicine workflow problems. People brought up questions that were of major concern that we didn't know people would ask, like, oh, I have a patient that's booked in Oklahoma and on my schedule. And we had to talk about that. And then, some of the doctors were like, oh, I'm giving my patients a 2-hour window for their appointment, like their Comcast or something. And we were like, you can't do that. And people were using other applications as sort of a backup method. And while that's probably a good idea, we had to really limit the scope of those backup applications. And with all of that, everyone had a real good sense of being informed and of really pitching in and saying that this is, something that everyone is owning. With Zoom, our staff and providers were unhappy with the process of getting a patient into Zoom. The provider had to schedule the appointment. They had to send the link to the clinic staff. The clinic staff had to work and send them back the appointment outside of that. So that workflow was a little clunky, and it was starting to wear on people after 6 weeks. but they really liked the app. They really liked the way Zoom looked and the way they interacted inside of Zoom. So they kind of took the good with the bad. In the beginning, we had our providers in clinic seeing patients by telemedicine in the clinic so they could receive support. But right before the beginning of April, we transitioned to a work from home model. And our clinic staff went home, our providers went home, and we maintained a skeleton crew in clinic for those rare in-person appointments. And I was afraid that we would run into more issues because everyone was at home. We were dealing with home networks, but by and large, we have had a lot of success with everyone being at home. Our no-show rates are down. Our patients are excited to see somebody that's not their family member on camera. And they're glad that they can keep their appointments. And then just one of the biggest things that we've learned, that we're all here together and we're here to work together. We are more supportive of each other than we thought, and we are more nimble and more adaptive. But for the university as a whole, we learned that some additional things that we were doing outside of the department. We set a clear workflow for initiation. We found that if we don't tell people up front what the expectation is for how this is going to work, they're going to make a lot of assumptions, and it's hard to dial back those assumptions. And that's really true for anything new that you introduce into clinical work. Calling the patients ahead of the visit is really important. It is very time consuming to call the patient the day before the appointment and make sure they got the link and walk through them testing the system. But that has made all of the difference in the departments that have really ingrained that into their workflow. Reimbursement is still complicated. Our revenue cycle team is slowly leaking out all of our charges because, especially commercial plans, we're making changes daily. Once they saw that Medicare and Medicaid sort of stabilized, they started releasing those charges. But just combing through the commercial plans has really been a challenge, and they've been hesitant to release a bunch of bills to a bunch of plans and then just wait for all those denials. We learned that these new patient forms and ways to contact patients outside of the telehealth platform were very hard to do if you didn't have a patient in the portal, but we learned through Qualtrics. We used our university resources to send secure email. So those are the big things that we had to kind of adapt to. Everything can be done by virtual now. You don't have to have classrooms anymore. I think that's what the schools are telling us. We're a school, that's what we're telling our students, but we leveraged the heck out of virtual sessions. We reached so many people so quickly because we were able to use WebEx as our teaching tool. Publishing those tools and guides and those workflows early, again, that keeps people from emailing you 70 times a day and asking all the same question, and it sets that expectation up early. And as a university, we are adhering to processes as close to pre-COVID-19 as possible. Where we can, we are maintaining written consent, and we are narrowing the number of platforms that people can use down to like 2 or 3. We've absolutely said no one can use FaceTime, no one can use Skype. Those are the things that we have definitely said that can't be done. And that the final thing about telemedicine and outpatient telemedicine in general, it's so much easier to do than you think. I think we get wrapped up into the details of how to do something rather than just doing it. And in COVID-19, we were given that opportunity to just run forward and go after it. And I encourage, if you haven't taken that leap yet, to do it now before it's too late. And that's the end of my slides. And I will go to Dr. Zapp. Oh, I'm sorry. It's not the end of my slides. Okay, so one of the questions that I get most commonly is, what do you think will happen post-COVID-19? It's a really hard question to answer. And on these CMS-led calls that I've been on, they've been asked pointedly about what they will relax for the future, what they're going to roll back. And they're just like, oh yeah, we're thinking about it. I know that patients will demand to still have telemedicine. I know that doctors are going to demand to still have telemedicine for their patients. So those two things are going to be the biggest drivers as to what gets rolled back. I do believe that HIPAA restrictions will likely return. Zoom showed us some very big sort of like danger signs as to what could possibly happen when you don't vet things carefully. And we as a department are transitioning off of Zoom and going to the practice plan platform because of those security concerns. And there will be lots of research on the quality of these visits, the cost savings of these visits. I have on the list on my desk, there's 5 grants that I am supposed to be applying for that address all these things for telemedicine. So those big quality and cost issues that we have sort of looming out there, I think that will be addressed in the very near future. And that is the end of my slides. Dr. Zapp.
Great. Thank you both, Teddy and Christy. So we're going to go into the question and answer portion now, and we'll open it to both of you. So the first question is, what factors have led to a decline in neurologists providing hospital call and inpatient consultation?
Well, I'll take that one. So in a lot of our community hospitals that only had a few neurologists already seeing patients, they were already getting a little bit older and getting to the retirement age. So a lot of them were no longer required to take call, and they decided to just maintain a complete outpatient practice or only show up sporadically when patients had insurance. In addition, some of the other hospitals that kind of fell into those situations as well is that if they weren't being reimbursed by the hospital for their time in taking call, essentially reducing call pay, they had no incentive to then even come into the hospital if it wasn't required by their bylaws. And it actually was much more financially beneficial for them to stay purely outpatient than inpatient. So I think those two are the biggest drivers in that decline in the inpatient coverage.
Right. What about, why has it taken a pandemic for telehealth to catch on?
I can take that one. Because it was way too difficult to provide care that way and get reimbursed for it before this. That was the biggest barrier I know of from most people, is that I can do all the telemedicine I want to, but I'm not going to get reimbursed for it at all. And people were worried about crossing those free care lines, especially with CMS. And that was a huge barrier.
And can either or both of you discuss the reimbursement for both inpatient and outpatient and how we're now coding?
I'll talk about the telestroke aspect of it. So we all know that starting, was it last year or this year?
Yeah, last year.
Last year, Jan 1, the acute stroke was being reimbursed by Medicare. So starting last year, we were billing patients for acute consults that we were seeing in the emergency room. That was the only restriction that was lifted with the bill that had passed. So now, well, we're still continuing to do so. We're billing the G042, 425, 426, 427 for initial ER or inpatient telehealth consultations for our patients. And we're billing specifically using time because it is often very difficult to achieve all the components that you would require for those head level billing. So I believe that the breakdown is 30, 50, and 70 minutes. And then we would just drop charges on those patients using that code. Now that the restrictions have come off, in theory, you're actually can bill for follow-ups as well, or non-stroke inpatient or ER teleneurology consults. Christy, I don't know if you want to talk about the outpatient part.
Yeah, I mean, the outpatient part was pretty much just transitioned over to the same way you bill for inpatient care. A lot of the review of systems were going to be missing from a virtual exam, so we did choose to do time-based as well. We asked that everyone document the start and end time of their visits, as well as any time that they spent preparing for that visit, reviewing imaging, things like that. So we did choose to go the time-based route for outpatient visits as well.
Okay. Could either or both of you discuss the difference in reimbursement in terms of a telemedicine visit versus an actual phone call? And are there differences for increasing the time intervals spent on the phone versus telemed?
So I think that the easy way to view telemedicine, which we are doing video, is actually it's the same time intervals that you would be billing for a face-to-face. either the same exact codes that you would be using, like the 99201 to 99205 and the 99211 to the 99215, which is established new patients. It's the same physical codes that you'll be using. Now, the telephone code specifically, and Christy, you could correct me if I'm wrong, but the new CARE Act and all those things, the lifted restrictions in that Medicare was not reimbursing telephone consults. Yeah, now that's now they are. Mm-hmm. So the codes 99441, which time spent is 5 to 10 minutes on the phone, 99442, which is 11 to 20 minutes, and 99443, 21 to 30 minutes. Now Medicare, they're reimbursing for it. Obviously, the telephone-only codes reimburse much less than the telemedicine codes.
And also, if you're spending more time than what the codes allow, that last telephone code is 30 minutes, but we had a provider on a call with a patient for over 45 minutes. And what we have tried, and I don't know the success rate of this yet because we don't have that denial if it didn't, but we're stacking codes. So we're stacking that 5 to 10 minute code with that 30-minute code to make sure that all that time is covered.
And can you include time spent on chart review prior to the visit in the total bill time?
So it can't be more than 50% of the actual exam. So if you spend 15 minutes on the exam, the virtual visit with the patient, and you do 10 minutes or 15 minutes of record review, then those together make 30 minutes. It just can't be 30 minutes of record review and 5 minutes with the patient.
Okay. And then another participant asked, Doximity also has a video option that is faster than Zoom. Do either of you have experience with it? And does billing matter for what type of platform has been used for the encounter?
So we do not use Doximity's new video component. That is something relatively new that Doximity has come out with. And so I don't have any experience with it. I don't think Dr. Wu does either. And what was the other half of that question?
Does it matter which type of platform you use in terms of billing?
No.
Okay. All right. What about how appropriate is the use of Teleneuro for inpatient and ER consults or code strokes to avoid exposure to trainees, specifically in the setting of a small program size or busy census?
I think it's very appropriate to use in the current crisis that we're in to limit exposure for all of our practitioners, since I don't think it's necessarily a trainee issue. We've transitioned some of our telestroke sites that have physical neurologists during the day to telemedicine for this specific reason. But I do think that would have to be peeled back at some point, because you do not want to rob our trainees the experience of their training and going pure telemedicine even beyond the COVID crisis. So gauging how to get back into some sort of normalcy would be a little bit harder to deal with, and when is it safe to be practicing face-to-face. I know that some of the bigger stroke centers have used and transitioned to telemedicine, that the trainees are no longer running physically to their code strokes. We have not done that. We are still face-to-face here locally.
Another question is, who in our institution were the key stakeholders to help review, approve the budget, or implement our telehealth system?
We're laughing at this question because I think in a normal institution, whoever is in charge of your practice plan, if you have a hospital, whoever's in charge of, sort of new models of care, you need a physician champion. You need a doctor driving that and saying, this is going to be key for our patients. But, the finance team, you need a lot of people, but here at UT, we kind of call it our little after school club. Dr. Wu, one of our pediatric surgeons, and I really drove this whole thing for the university and kind of force them into adopting a platform for the practice plan. We don't have our own hospital. We have a training partner hospital. So there wasn't like this big health system that we could sort of leverage to justify an outpatient telehealth platform. We really just, approached it as, this is what's best for patients. This is what's best for providers. And this is how we're going to solve some of those care gap issues. So if you don't have a big administrator in your corner, I encourage you to start your after-school telehealth program club and see what you can do with that.
Yeah, I think, it kind of goes along with the previous question about why the pandemic kind of jump-started everything. So Christy and I have been doing telemedicine here at UT since 2011-ish. And overnight, essentially, COVID has done more. Well, we've been trying to kind of get things jump-started, but overnight, it's almost forced upon everybody. And now everyone was knocking down her door to try to get this done. So I think, now that we're being forced to do it, everyone, I think, is embracing it of some sort. I think we have to take a step back at some point when COVID is over to figure out what's the right way to do things. When was it appropriate to do telemedicine? When was it not? If they dial back the restrictions, whether that's billing or technology, how are you going to deal with that? And who are the key stakeholders, such as, for us, the president of the university or our dean, our practice plan, all of our division chairs, are really need to go into play. And this is the right time to kind of assemble that team, because right now we're all being piecemeal together. But at some point you'd have to have some form of structure after this all goes away.
Another question we had is, are nursing staff able to help with the consults if we're not able to go into the room? Would they even utilize an iPad or iPhone to help out with the process?
Yeah, so I think that's an important question. A lot of our teleneurology sites, at one site we have a nurse practitioner that we've trained that helps with our neurology consults. But at most places, even in the ER, it is a nursing-driven program. Our nurses are the ones that are helping us examine the patients. Now, in the COVID crisis, they always, safety first. They have to put on the gowns and make sure that the mask and the gloves are on. But they are the ones that we interact with about 99% of the time. And it's not the ER physician or it's not the hospitalists that show up. It's our nurses that understand the protocols and what information we need. So yes, the nurses are more than capable of doing this with proper instruction. And that's why training the physicians on our end to how to communicate with the nurses about what we need, what we need to do, how to position the camera, how they can help with the exam is very, very crucial. So even before the COVID, we were training everyone constantly on how to approach this.
And the last question that we have, it might be more for Christy. Is there, for outpatient, are there ways to set up predefined appointment durations for each type of appointment? Perhaps a timer that's visible to both the MDDO and patient?
So that is going to be sort of specific to whatever platform that you're using. The platform that we use doesn't have that capability, but that doesn't mean that another platform doesn't. We went through a massive RFP to find the platform that we ended up using. And if that's a feature that's important to you, if you go out looking for a platform, then you need to make sure that you note that, but our platforms specifically do not.
Okay. And then the final question that we had is, can I use regular iPads for my encounters?
Yes.
Yeah, I think the answer is yes, but it depends on what you're using it for. You can use your phone, you can use whatever, but if you're doing acute stroke from a hospital to hospital, yes, you can use an iPad, but is that the ideal situation? Is that good enough resolution? With an iPad that you're going to have to move around, or does a nurse have to hold? You got to think about, is that the right situation? If you're seeing somebody at home, that's different, right? If they're just showing you their recent scar after knee surgery, yes, they don't, that's very easy to be done. So the right technology for the right setting, right type of visit, I think, again, those are the things you need to think about beyond the crisis. Because right now you can use everything under the sun. You just want to be able to talk to your patients and see your patients, but to do it well and do it properly, there needs to be more thought afterwards.
Okay, great. I think those are all the questions. So to everyone who's logged in, we're going to be taking a quick break before our next presentation. Just a reminder that there will be a survey at the end of the webinar that you could ask any of our speakers additional questions. And if you need to claim your CME credits by the end of today or tomorrow, please direct your attention to the attendee portal. Okay?
Thank you.